Uh, Again, we are meeting once again. This is a very enthusiastic program as far as we are concerned. I hope the students will also feel that it is worth listening. So today, we are going to have a very important aspect in dermatology. Of course, we know that leprosy is eradicated from India, but we are getting a lot of cases of leprosy in day-to-day practice. I hope all the medical colleges are having the same experience. So I thought it is important to know the current treatment of leprosy. There are a lot of revisions have occurred in the field of leprosy as well as in the treatment of leprosy. So we must be very conversant with the current treatment protocol. Otherwise, we may fall in the old treatment and there will not be a uniformity of treatment protocol. So that's why this particular topic is selected. Moreover, you may get, from the examination point of view, you may get Pradeep Nair as the speaker. There is a special importance for choosing Dr. Pradeep Nair. Pradeep Nair is a very good orator. He is very much interested in the field of leprosy. And he has published a lot of articles, a lot of presentations. So he is very much into leprosy. And he is a good teacher also. And you will hear from him how good he is. So I invite Dr. Pradeep Nair to deliver his class. Thank you.
Good morning, everybody, and thank you, respected senior and most dermatologists in Kerala, Professor Crichton sir, for a very kind words. And I appreciate your kindness in inviting me to give this talk. And also my thanks to the East West Pharmaceuticals for making this reality. Treatment of leprosy, as sir has very correctly said, that even though we are in the elimination phase, day by day we are seeing new cases, and unfortunately we are seeing even the smear positive cases. So today my talk will be on the treatment of leprosy. There are some new aspects which WHO has advocated and NLP has taken it also. So it will be very useful for the JRs who have recently joined. I'll confine myself to treatment of leprosy and a word about Lepra reactions and vaccine. But there is a small homework for all the JRs today. Today, after this webinar, please go to your home, take that standard textbook, Ridley and Job, and read the mechanism of action and adverse reaction of these drugs. That is not the purview of my talk today. That is your homework. Now we'll look at certain milestones in the treatment of leprosy. In 1982, the WHO advocated the MDT, multi-drug therapy, which means 2 or more drugs for treating leprosy. In India, it was incorporated in 1983. And again, the multi-drug therapy is divided into posi-bacillary MDT and multi-bacillary MDT. In 1998, the WHO came with the FDT, so-called fixed duration therapy. Previously, once you start treating leprosy, especially a smear positive case, we continue treatment till the smear becomes negative, but not so now. Now, after 6 months in posi-bacillary, after 12 months in multi-bacillary, we stop the treatment, whatever be the condition of the patient. That is known as fixed duration therapy. Not very scientific, but that is what the WHO is advocating. And whatever it is, multi-drug therapy has gone a long way in reducing the prevalence of leprosy, less than 1 in 10,000. This is the parameter taken by WHO to declare elimination of leprosy, even though epidemiology is not at all correct, because by definition, Elimination is defined as the reduction of a particular disease, that is the incidence, I repeat, the incidence and not the prevalence, to zero in a particular geographic area due to treatment. So that is the correct definition of elimination. So what it is, we shall go forward. Now, what is the rationale for multi-drug therapy? This is same whether it is TB or HI, where we are combining 2 or 3 drugs together. And most important, you can notice that all these 2 or 3 drugs have got different mechanism of action. The rationale being that is very unlikely for a parasite to develop resistance to 2 or 3 drugs at a time. Now we go to the basic scientific level, the rationale MDT. In a given case of untreated lepromatous leprosy, may be 10 raised to 11, 10 raised to 12 M lepra, of which 10 raised to 10 are the viable or the live. In an untreated case of leprosy, also you can find dead forms of bacilli. So in this 10 raised to 10 viable lepra bacilli, 1 in 10 raised to 7 will develop resistance to rifampicin naturally, that is even without treatment, whereas 1 in 10 raised to 6 will develop resistance to DAMPs. So it means what's the initial parameter again? 10 raised to 10 viable organism. If 10 raised to 7 can, 1 in 10 raised to 7 can develop resistance to rifampicin. Definitely this particular group will contain 10 raised to 3 already resistant rifampicin, that is 10 minus 7. Same case in DAMPs 10 minus 6 will be 10 raised to 4 DAMPs resistant strains. So when I start multi-bacillus, multi-drug therapy, the drug sensitive strains will be taken care of by rifampicin DAMPs. Not what about this 10 raised to 3, 10 raised to 4? Simple, clofazimine will take care of it. So that is the rationale of multi-drug therapy. Now, what are the chances of this particular organism developing a drug resistance to 2 drugs at a time? Here I am talking about secondary drug resistance. In a viable population, 10 raised to 10 bacilli, if 1 in 10 raised to 7 can develop resistance to rifampicin and 1 in 10 raised to 6 can develop resistance to DAMP. So the chance of the M. lepra developing resistance to 2 drug will be very unlikely, because then it must be 10 raised to 7 plus 10 raised to 6. There must be 10 raised to 13 organisms. Not possible here because we already have 10 raised to 10 viable organisms. But keep in mind, if the patient is infected with a de novo resistant strain to multiple drugs, then these numbers won't come into play. So this is the fundamental rationale starting multi-drug therapy. Now, what is the pre-workup you do before starting treatment in leprosy? We do blood routine, liver function test, renal function test, chest X-ray. Now comes a question, why chest X-ray? All of us know mycobacterium lepra does not affect the lungs, the brain, the heart. Then why a chest X? That is because in our therapy in leprosy, we give monthly rifampicin, whereas the therapy for tuberculosis is daily rifampicin. Unfortunately, if this particular patient has got an undetected tuberculosis and we are giving only anti-leprosy therapy, that is monthly rifampicin, you are asking for drug resistance of mycobacterium tuberculosis to rifampicin. Hence, chest X-ray is mandatory. Now, just a brief trip down the memory lane. On the left-hand side, you can see the classical first-line drugs given in Hansen disease, Damson, clofazimine, rifampicin. Of this, the proved bactericidal drug is rifampicin. Along the second-line drugs, we got ofloxacin, minocycline, clarithromycin, levofloxacin, oxyfloxacin. Now, I put an underline under minocycline and clarithromycin. Suppose we are encountering a situation where you have to give the second line drugs. Ofloxacin is freely available, but many situations, unfortunately, minocycline, clarithromycin may not be available and the patient may have to buy it in the pretty expensive. Now, what about levofloxacin, oxyfloxacin? WHO says that suppose we give the second line drugs, if ofloxacin cannot be given and not available, you can give levofloxacin and moxifloxacin. Now, the classifications for treatment purposes is advocated by WHO and NLP follows it. That is a National Leprosy Eradication Program. For that week, this is the latest classification. We classify leprosy into paucibacillary and multibacillary. Paucibacillary means up to 5 skin lesions, no nerve involvement, smear negative. Multibacillary means 6 or more lesions, nerve involvement, and smear positive. So this is the universal classification for treatment purpose in leprosy. So now we go to the treatment protocol, paucibacillary. In paucibacillary, we give dapsone 100 milligram daily, clofazimine 50 milligram daily, rifampicin 600 milligrams given monthly. And this is given for 28 days. Actually, the blister pack is given free to the patient as a part of NLP because leprosy is a national control program. And each blister strip contains drugs only for 28 days. I repeat, 28 days and not 30 or 31 days. And this 28-day cycle is given for 6 months. Now I put an underline under clofazimine. Very correctly, Crichton sir has said that there are new changes that come to treatment. This is because now in paucibacillary, WHO and NLP has decided that clofazimine also in the paucibacillary, which is not present previously. Now, why this is so? Because there are two reasons. One, it makes the field work easier because now we don't have a particular program. But more important scientifically, suppose a multibacillary is wrongly classified as paucibacillary and given paucibacillary, clofazimine will take care of it. That is the reason. What about multibacillary treatment? Dapsone 100 milligram daily, clofazimine 50 milligram daily, monthly rifampicin. But in addition, we give clofazimine 300 milligram. Again, it's a 28-day cycle for 12 months. Now, why this monthly clofazimine 300? We are giving daily. That's because the drug clofazimine has got a very peculiar pharmacological property. It is a fatty bound drug and it is deposited in the fat tissue, has got a depot effect. So even if the patient misses 2 or 3 doses of clofazimine, this monthly 300 milligram will take care of the missed dose. Now you may be wondering why you should be bothered clofazimine being missed. We have got rifampicin clofazimine because the least chance of mycobacterium lepra to develop resistance to any of the first or second drug is clofazimine. That is the reason. Now, after 6 months in paucibacillary and after 12 months in multibacillary, we have followed a fixed duration therapy. We put the patient what's known as RFT, released from treatment. The patient is asked to go away, whatever be the condition of the patient. And now, recent, we know, just last year, the NLP has come with the so-called SDR. All the family members of that index case are checked for evidence of leprosy and TB and given a single dose of rifampicin for prophylactic therapy. That is known as SDR. Now, what about in children? Children 10 to 14 years, we won't give 600, we give rifampicin 450 milligram. Instead of the monthly clofazimine 300, we give 150. Of course, dapsone is 50 and clofazimine 50. Now, less than 10 years of age or about approximately 30 milligram per kilogram body weight, then we give rifampicin milligram per kilogram body weight. Rifampicin 6 milligram per kilogram body weight. Clofazimine 6 milligram per kilogram body weight, monthly dose. Dapsone daily 2 milligram per kilogram body weight. Clofazimine 1 milligram per kilogram body weight daily. Now, once you start the therapy, when do you say a patient has taken adequate treatment? Who is at default? In a paucibacillary case, a patient who has taken the above mentioned 6 cycles within a period of 9 months. In a multibacillary patient, a patient who has taken 12 pulses within a period of 18 months is considered adequate treatment, which means we are giving a leverage of 3 months in paucibacillary cases and 6 months in multiplex. Please do not encourage it. It is possible for some patients not to take this drug. So suppose a patient is not taken positive bacillus for 3 months, multiplex for 6 months, then the patient is coming you. Simple, you continue from where the treatment was stopped. But on the other hand, we have got a positive bacillus patient who has not taken 3 months treatment for greater than 3 months and multi-bacillus treatment more than 6 months. Then this particular patient qualifies as a defaulter. And when this defaulter comes to you for fresh treatment, we restart from day one. That is the difference. Now we're coming to the treatment different scenarios. This is a case of Hansen disease BT. You can see the satellite lesion. The pre-workup was done, blood routine, LFT, chest X-ray, all normal. I started MBMTT because the patient had 2 nerves also. And ideally, it is better to repeat the blood routine and the liver function test after 1 week to see if there are any enzyme abnormalities. This particular patient, very common, the blood routine was normal, but the LFT was abnormal. Now keep in mind, we are giving 2 potential hepatotoxic drugs in leprosy, Damson and Rifampicin. So what to do? Now, you need be bothered only if the hepatic enzymes are elevated 3 times the norm. Up to 1 or 2 times is normal. You develop a respiratory tract infection, you take 5-day course of azithromycin and 2 or 3 days of the Dolo 650. If your hepatic enzymes are not elevated, there is something seriously wrong with your liver. Which means I'm saying that any drug which is metabolized by the liver, after taking this drug, there will be a transient elevation of the hepatic enzymes. So in a particular case, I have started MBT. It's more than 3 times the normal. You stop MDT. Repeat the enzyme after 2 weeks. After 2 weeks, it is normal. You can take it for granted. It's only a transient hepatic elevation enzymes. You continue and restart MDT. But even after 2 weeks, I'm doing the LFT, it is not normal. Then stop Damson and Rifampicin because both are hepatotoxic drug. Definitely it is Damson much more. What to do? You repeat, in meanwhile, definitely you can continue clofazim because clofazim is not hepatotoxic. Again, you repeat the enzyme after 2 weeks. If it is normal, you can restart MTT with daily clofazim, monthly rifampicin. The medical gastroenterologist advocate not to restart Damson any time if you have gotten hepatic enzyme problem. So you restart the rifampicin, continue clofazimine, again repeat enzymes after 2 weeks. It is normal. You can continue with daily clofazimine, monthly rifampicin. But even after 2 weeks, enzymes are elevated indicates it is both rifampicin and Damson. And then we go to the alternate regime. Now, alternate regime is WHO recommended and is given by NLP also. In the alternate regime, we have got an induction phase and a maintenance phase. In the induction phase, you give clofazimine 50 milligram daily, ofloxacin 400 milligram daily, that is second line drug, minocycline 100 milligram daily into 6 months. After 6 months, we go for the maintenance phase. Clofazimine 50 milligram and ofloxacin 400 milligram or minocycline. Either ofloxacin or minocycline. I personally prefer ofloxacin because it is cheap, effective, easily available. Rifampicin is expensive and has got some adverse effects. It is given for 18 months. So total it is 6 months to 18 months. So the alternate regime is for 24 months. Now again, and important, these are all real lifetime scenarios. HTBL, you can make out the infiltrated papules. Pre-workup normal, I started MBMTT. The patient developed dizziness, fatigue, etc. When I did the blood routine, there was anemia and the reticulate sound was elevated, which means this is nothing but Damson-induced hemolytic anemia. Most probably this patient is having glucose 6-phosphate dehydrogenase deficiency. What to do? Stop Damson. When a patient develops Damson-induced hemolytic anemia, there is no grounds to restart Damson. It should not be started. How do you go? In a in a positive bacillus case or a smear negative multibase, easy. You continue daily clofazimine monthly families. It will be sufficient. But a multi-bacillus smear positive case, because I'm removing an important Damson, you can add ofloxacin 400 milligram daily or give the alternate regime. Now, and the important scenario, patient is unwilling to take clofazimine due to pigmentation, because nowadays there's net is there. Every patient will go and assess and educate patient. So this is going to cause pigmentation, especially in fair skin individuals, it becomes a problem. My personal experience is whenever a patient says they cannot take clofazimine, I always advise them, no, this is a very important part of the regime. I tell them the pigmentation is reversible. 6 months to 1 year later, it will disappear. Because, as I mentioned earlier, the least chance of M. lepra to develop resistance is to clofazimine. But still then in a die-hard patient, no, he says, no, I don't want to, I'm not going to take it. Fine. In a posi-bacillus or multi-base smear negative case, we can continue daily Damson or rifampicin, no problem. But in a smear positive case, you have to add ofloxacin 400 milligram. There is no scope for alternate therapy because the alternate therapy contains clofazimine. Now, in the scenario, we are given posi-bacillus therapy to patient as relapsed. If a posi-bacillus patient relapses, but you give multi-bacillus therapy. Simple. Now, a multi-bacillus patient who smear negative has relapsed, and there are no facilities to confirm drug resistance. Simple. You continue the multi-bacillus immunity for 1 year more year. But if a multi-bacillus smear positive cases have relapsed, it's most likely to be due to drug resistance. You give the alternate regime. Now, another scenario, lepromatous leprosy, very high BI, 6 plus MI, 72%. MB entity was started. There is no sufficient clinical improvement. After starting multi-bacillus therapy, we expect the morphological index MI to become 0 within 4 to 6 weeks. If it is not coming down, it is a very strong indicator of drug resistance. Now, the only way to prove drug resistance is you send the tissue to Chengalput Shefflin Institute, 2 institutes there in Karikal, Tamil Nadu, and they are doing now the DNA PCR. Most like in a multi-bacillus case is actually resistance to rifampicin. But we have got a suspected base, but we cannot prove. I cannot send it because it is expensive. It costs 4,000 to 6,000 rupees to do the drug resistance test. You give the alternate regime. For that matter, in any regime where we cannot give rifampicin, give the alternate regime. Again, a case of the histoid leprosy, most bacilliferous type of leprosy, 6 plus MI 75% MB entity started. No improvement, tardy fall in BI. This is our patient, doesn't publish. A drug resistance showed resistance to both to rifampicin and ofloxacin together. Probably de novo this patient has been infected. Now we got a big problem here. The first line bactericide and second line bactericide is resistance. Now how do you manage? Now we go to what is WHO advocated alternate regime. Again, that has got an induction phase and a maintenance phase. Induction phase, clofazimine 50 milligram daily plus clarithromycin 500 milligram daily plus minocycline 100 milligram daily into 6 months. After 6 months, you go for the maintenance phase. Clofazimine 50 milligram and minocycline 100 milligram or clarithromycin. Here I prefer minocycline because it is less expensive and less toxic than clarithromycin, because clarithromycin is not that easily available and it's notorious to cause gas. It's again for 18 months. Minocycline should be 100 milligram. So again, 6 months to 18 months gives 24-month therapy for the alternate regime. Special scenarios, pregnancy and lactation. All the first-line drugs, dapsone, clofazimine, rifampicin can be given, but none of the second-line drugs, that is ofloxacin, clarithromycin, minocycline, cannot be given. Now you may, question will pop up in your mind. If I can give azithromycin, if I can give erythromycin during pregnancy, why not clarithromycin? Because clarithromycin also is a macrolide antibiotic. Reason is simple. There are no sufficient animal studies done with regarding clarithromycin to indicate this teratogenesis. Hence, do not give. Special scenarios. You can see a 36-year-old female HTBT. You can make the edematous erythematous plaque. Possibly she is a type 1 reaction. Pre-workup is normal, but unfortunately the chest X-ray you can see has shown a cavity suggestive of pulmonary tuberculosis. So this patient has got both leprosy and TB. So how do you proceed? Keep in mind, in pulmonary tuberculosis, we get category ATT1, which includes daily rifampicin. So when the patient has got concomitant ATT, there is no need of our anti-leprosy rifampicin monthly. 6 months, no problem, but we are giving 12 months for positive bacillus. ATT is given only for 6 months. So after 6 months, in a multi-base case, simple, you start monthly rifampicin. Special seniors, this patient is HTLL. You can see the subcutaneous nodules, pamphlets, plaques, and HIV positive is on ART. Now, this patient has got both leprosy plus HIV. As far as possible, there is no much change in our range. But for 6 months to 1 year in a HIV positive patient, since dapsone is given, there is no need for co-trimester prophylaxis against PCP pneumonia for HIV positive patient, because dapsone is as good as co-trimester for prophylaxis against PCP pneumonia. But there is a big type problem. They are giving a monthly rifampicin, and all of us know now the universal 3-drug regime for HIV infection is the TLD regime. Tenofovir, lamivudine, dolutegravir. Dolutegravir is actually an integrase inhibitor. And unfortunately, rifampicin is a hepatic microsomal enzyme inducer, which means the day you give monthly rifampicin for leprosy, the dose of dolutegravir is doubled to 50 milligram BD. The standard dose is 50 milligram OD. Now we're coming to a very special, even though it is not a purview of the talk, Lepra reactions. All of us know that Lepra reactions acute exacerbation the clinical signs and symptoms of leprosy because of the change in immunity. We have got type 1 Lepra reaction, we got type 2 Lepra reaction. In a mild type 1 Lepra reaction, where the patient will present with the edema, erythema of the skin lesions, and maybe new lesions. Simple NSAIDs like aspirin, 300 to 600 milligram, TDS can be given. Hydroxychloroquine, 200 to 400 milligram, even diclofenac, sodium, indominus, etc. can be given. In type 2 Lepra reaction, classically presents erythema nodosum leprosum, seen usually in LL patients, sometimes in BN also. Here we can exploit the anti-inflammatory effect of clofazimine, make it to 100 milligram TDS, which is actually the anti-inflammatory dose, even though nowadays WHO does not encourage the giving of this high dose of clofazimine, mainly because of its gastric adverse effects. And of course, resistant type 2 Lepra reaction, the drug of choice is always thalidomide, 100 milligram TDS. Now we are coming to a special situation. We got a very severe type 1 Lepra reaction with ulceration. Whenever you got a severe type 1 Lepra reaction with ulceration, invariably neuritis is a part and parcel of it. Hence, there is only one treatment, systemic steroids. The dose of 0.5 to 1 milligram per kilogram body weight, universally validated and it is effective. The alternatives are methotrexate cyclosporine. I have not tried, but I'll tell you and given writing, they are inferior to systemic steroids. Now, a word about treatment of neuritis with steroids. Nowadays, we follow the flexible protocol. The old WHO regime of 40 milligram prednisone for 12 weeks, 3 months, is not at all adequate or sufficient to treat neuritis. We follow the flexible protocol. Flexible means the dermatologist will decide the dose and the tapering of the steroid and not fixed as advocated by WHO. So for neuritis, we start a starting dose of 40 to 60 milligram. Always start 60 milligram. I am of the opinion neuritis must be aggressively treated. You forget adverse reactions, that will take care of. You continue this dose till control, reduce by 5 milligram every 1 to 2 weeks till it reach 20 milligram. Then 5 milligram every week. So it may take about 12 to 20 weeks. So keep in mind, 40 to 60 milligram, 12 to 20 weeks is the flexible, most effective regime for neuritis. Now coming on the very important problem in hands and the recurrent ENL, which is a big headache because a recurrent ENL can occur even after the treatment has stopped. Now, how do you define recurrent ENL? An erythema nodes and leprosy that has occurred within 28 days after last stopping treatment of the previous ENL is known as recurrent ENL. In recurrent ENL, now the established treatment is a combination steroids 14 milligram plus thalidomide 100 milligram TDs. You start steroids alone or thalidomide alone is not going to work. You have to start this regime together. And thalidomide later can be taken as 100 milligram BD and 100 milligram OD. This is very effective for recurrent ENL. Alternatives are TNF alpha inhibitors, etanercept, infliximab. I have not tried. Two new drugs are there for treating. One is apremilast, even the anti-Hansen drug, minocycline. But nothing can beat a combination of steroid plus thalidomide. But nowadays, concerns are being raised that a recurrent ENL can be a manifestation of drug resistance. Now coming on the what is a necrotic ENL where the erythema nodes and leprosy ulcerates necrotic ENL. This is a very severe condition and always requires steroids and dose of 40 to 60 milligram per kilogram body weight. Because a patient has got extensive necrotic ulcer, please send a pus culture and sensitivity. And broad spectrum antibiotic is required, otherwise the patient will die of septicemia. Now, I'm just mentioning certain newer drugs used for reaction in type 1. You can use azathioprine, methotrexate, cyclosporine, interferons, tacrolimus, and the interleukin 6 inhibitor, tocilizumab. Type 2, pentoxiflin, oral zinc, infliximab, I mentioned, etanercept, and the new drugs are minocycline. Possibly minocycline is being used because it's anti-inflammatory action. Now, coming word about vaccines and leprosy, definitely within 4 or 5 years, this is also going to come as a part of the multi-bacillus therapy. The classical are the left side, the BCG, the killed mycobacterium lepra, the ICRC based Indian Cancer Research Institute, Wesley, mycobacterium, but now universal now is the MIP vaccine, the mycobacterium indicus prani, the only vaccine which is actually okayed by the FDA of usage to treat Hansen. It's the only vaccine which is advocated by FDA. We give 2 doses classically, 6 months apart. Can be combined along with MBT. People have shown that, studies have shown that rapidly reduce alone, or it can be given as a part of prophylaxis for the family members. Now, certain studies are going in North India, but it is not being accepted universally. There's an alternative vaccine, Lepra vaccine, which makes use of the protein components of the vaccine. So the points to ponder in conclusion are multi-drug therapy has gone a long way in reducing the incidence and prevalence of leprosy, and we can claim maybe elimination has occurred. But at the same time, keep in mind, leprosy drugs are few. Do not change the regime if there are no significant counterindications. But same day, do not wait for drug-resistant reports. Use your clinical judgment. And within 4 or 5 years, I'm sure NLB will incorporate multi-drug therapy with the big vaccine. And we can hope a faster reduction of lepra and increased improvement. Thank you.
Thank you, Dr. Pradeep. It was very wonderful. I mean, I have to congratulate you for the lucid presentation. And of course, the postgraduate will have a very good idea about the treatment of leprosy, especially because you have incorporated a lot of clinical scenario which we all come across during the day-to-day practice of dermatology. And your practical approach is highly appreciated. And to the postgraduates, you have heard the beautiful lecture of Dr. Pradeep, and it is your duty to build on that that lecture. He has given enough and more knowledge to you, but that is not sufficient. You have to read and read about leprosy. It is even though the leprosy is in the process of elimination, don't neglect leprosy. That it is something which we should not read or like that. So somebody has coined the term neglected tropical diseases. So this is very, very important. The importance of leprosy is, I mean, when we were students, it is very much. But nowadays, especially when in the private medical college, there are less of leprosy cases because the drug available, for example, rifampicin in Kerala is a controlled drug. So we cannot treat leprosy as such. So patients, even if we come across leprosy, it has to be referred to the government medical college or government setup. So in private medical college, the students are not exposed to various problems of leprosy during treatment and before making a treatment. So it is your duty. At least you have to make a diagnosis and make a diagnosis of the complications while on treatment. So you have to read thoroughly. And as Dr. Pradeep has said, you have to read Ridley and Joplin. That is a very beautiful book. It is very small, concise, and it is easily readable. So make it a Bible for your leprosy studies and read thoroughly. Don't skip any sentence out of this Joplin's textbook. So I hope all of you understood the treatment of leprosy and you have enjoyed the lecture. On behalf of you and myself, I congratulate Dr. Pradeep for such a lucid
Thank you.
Talk. Thank you, Dr. Pradeep.
Thank you, sir. Thank you very much.
Yes, sir. In fact, I learned a lot from Dr. Pradeep talk. Thank you very much. And
thank you, sir.
So also, I am sure the postgraduate students learned a lot from your talk. Again, on behalf of them, I thank you profusely to you. And as usual, well, students enthusiastically participated in this. That shows the answering trend in the chat box. So good. We will have another session next month. almost the same period. Till then, thank you very much. Thank you, Dr. Pradeep, for it.
Thank you, sir. Thank you very much. Thanks, Naveen, also. Thanks a lot.
Thank you.
Beautiful.
Thank you, sir. So, Iswas Pharma really extend our gratitude to the speaker, Dr. Pradeep Nair, sir, has given lucid presentation benefit of our PGs. Almost 75 participants across India, they have participated. Two international students also I have seen in the chat box. They also actively participated, which seems the reach of our program. And our Iswas Pharma extend our gratitude to the course director, Dr. Ketan, sir, has conducting wonderful topics from renowned speakers across the country. So so the same way, the recorded version available in our Resource Pharma YouTube channel. So shortly it will also be uploaded. For the gift vouchers, the winners, we congrats once again. The gift vouchers as well as the certificates will be reached to you directly by our field force. So Resource Pharma always committed for the academic programs continuously. Next month we will see with the different topics with the different renowned speakers. Once again, we extend our thanks and hearty gratitude to the speaker as well as course director, and congrats for all participants, those who have participated across the globe. Thank you, Doctor.
Thank you. Thank you.